Well, I think there's a lot of exciting data and some trends happening in the atherosclerosis, atherothrombosis spaces. I think, one is we're finally starting to see some traction with the adoption of the COMPASS trial dosing of rivaroxaban in conjunction with low-dose aspirin for the reduction of atherothrombotic events, both morbid and mortal events, in patients with coronary artery disease, peripheral arterial disease, or both. COMPASS, as many of the viewers will recognize, is a trial that's a few years old, but it's a very important one. 27,000 plus patients were randomized to one of three strategies of low-dose aspirin monotherapy, low-dose aspirin plus low-dose rivaroxaban, and then rivaroxaban 5 BID. The combination therapy was 2.5 BID of rivaroxaban plus aspirin 100 milligrams a day. And the clinical punchline is that there was, at the end of a couple of years worth of follow-up, median exposure about 23 months, a 24% relative risk reduction in major ischemic events. And I think particularly notable was that in this study, each component of the composite endpoint was favorably influenced by the addition of rivaroxaban to the background of aspirin therapy. And so this is a couple of years old. The European Society of Cardiology acknowledged the value of this strategy in the 2019 guidelines update for patients with chronic ischemic disease. The US guidelines have been a little bit slower to adopt, but I think that finally we're starting to see some adoption in the clinical space of this ostensibly potent strategy for reducing cardiovascular risk. Yeah, so I think there's a lot of granularity to the COMPASS trial data in that on one hand, it looked at a very broad swath of at-risk patients who made it into the trial, the majority with CAD, the minority with PAD, and about 19% of them overlapping with CAD and PAD. I think the interesting thing about COMPASS is that the favorable effect of low-dose rivaroxaban plus aspirin, dual pathway inhibition, was notable in both the CAD cohort as well as the PAD cohort. And in some ways, the signal was even amplified in the PAD cohort. I think this becomes important because this is a very high-risk population of patients that we don't have a lot of great secondary risk reduction data for. And B, the findings were more or less recapitulated by the Voyager PAD trial. And C, the benefits in the PAD cohort seem to extend beyond just cardiovascular risk reduction to limb event reduction as well. So I think that becomes sort of an important secondary signal in a population of patients that are certainly present in all of our practices in abundance. And up until this point, we didn't have a lot of great strategies as we did for the pure CAD cohort. Yeah, well, there's, I think the regulatory environment is something that we're always beholden to, and the COMPASS trial dose of dual pathway inhibition, low-dose rivaroxaban plus aspirin, was approved by the FDA shortly after the publication of the trial and the secondary analyses back in 2018. And so there is FDA approval to rest on when we're using that dose. In sort of a slightly separate area, the MAGELLAN trial dosing of rivaroxaban as DOAC therapy, non-inferior to low-dose enoxaparin in acutely medically ill patients who were recently hospitalized and then discharged, also gained FDA approval around the same time frame. So those are the two big regulatory changes to that. Of course, in the antiplatelet world, there has been approval for lower dose ticagrelor in patients who are 1 to 3 years out from an acute myocardial infarction and so forth. I think, you know, with all of these antiplatelet and antithrombotic therapies, we look to the regulatory bodies as well as the guideline writers for additional guidance and input as to how to implement this in COVID-19 patients. Both the patients who are hospitalized and then discharged after an acute phase of illness, as well as the vast majority of COVID-19 positive patients who are weathering their symptoms at home with you know, limited or sometimes absent symptomatology. We recognize that that latter cohort of patients, the COVID-19 patients taken as a whole, do seem to have a prothrombotic milieu. Reasonable people can disagree as to what that means in terms of clinical sequela, particularly in the non-hospitalized cohort. And so we're still sort of scratching our heads a little bit and trying to apply older data to a distinctly newer problem that we've had in the past you know, year and few weeks.